Hello and welcome. In this explainer, we're going to walk through a really high-yield clinical pathway for managing male lower urinary tract symptoms, or LUTS. Think of this as a practical guide for your day-to-day practice and a super-focused revision tool if you're gearing up for exams like the MRCGP.
So here's our game plan. We'll start by classifying LUTS and looking at their causes. Then we'll get into clinical assessment and the tools you can use to quantify symptoms. After that, we'll break down 3 different management pathways, one for voiding symptoms, another for storage and overactive bladder, and finally, we'll put a special spotlight on managing nocturia.
All right, let's jump right in with classification. Lower urinary tract symptoms are incredibly common. They affect the majority of men over 50. And while benign prostatic hyperplasia is definitely the usual suspect, it is absolutely critical to keep a broad differential in mind, and that always has to include the possibility of prostate cancer.
Now, this classification into 3 groups, voiding, storage, and post-micturition, is fundamental. I really want to stress this. This isn't just some academic exercise. It's the critical first step that's going to guide our entire diagnostic approach and really shape the management plan we build for our patient.
So let's break down what goes into each category. On the left, we've got voiding symptoms. These are mainly obstructive things, like hesitancy, having a poor or intermittent stream, or straining to go. In the middle are the storage symptoms, which are more on the irritative side. Think urgency, frequency, and nocturia. And finally, on the right, post-micturition symptoms, which include things like dribbling after you've finished or that nagging feeling of incomplete emptying. Figuring out which of these clusters is bothering the patient the most is really the key.
Okay, on to our second section, clinical assessment. Once you've heard the patient's story, the next job is to move from their subjective account to some hard, objective clinical findings.
The core workup really has 3 parts. First up, urinalysis. We need to rule out an infection or any blood in the urine. Second, the digital rectal exam, or DRE. This is where you're assessing the prostate size and what it feels like. Are we talking a smooth enlargement, or are there hard, suspicious nodules? And third, PSA testing. But, and this is a big but, you must do thorough pretest counseling. The patient has to understand what a result might mean, including the risks of overdiagnosis.
Beyond the physical exam, there are 2 tools that are just indispensable for helping us quantify what the patient is going through. The first is a urinary frequency volume chart, which is basically a bladder diary the patient fills out. It tracks what they drink and their voiding patterns. The other is the International Prostate Symptom Score, the IPSS, which is a standardized questionnaire that gives us a number for how severe the symptoms are.
And these 2 tools do different jobs. The frequency volume chart is mainly a diagnostic tool. It's brilliant for telling the difference between true urinary frequency and something like polyuria. The IPSS, on the other hand, is for staging. It gives you a score that classifies symptoms as mild, moderate, or severe. This directly tells you what to do next and gives you a baseline to see if your treatment is working, which, for exams, is a really critical point to remember.
Let's turn to management now. We'll start with patients where the main issue is voiding symptoms. Trouble starting, a weak stream, or straining. The approach here is very methodical, step by step.
And the very first step for every single patient, no matter how bad their symptoms are, is to start with conservative, non-pharmacological measures. This is the foundation for everything that comes next.
So what does that look like? Well, we're talking about things like pelvic floor muscle training to improve support, bladder training to increase capacity and control, advising on sensible fluid intake, and maybe suggesting containment products to help with quality of life while we get other treatments going.
Now, if those conservative measures aren't enough for someone with moderate to severe symptoms, we start to climb the pharmacological ladder. Step 1 is an alpha blocker to relax the smooth muscle. If the prostate is big and you're worried about things getting worse, you'd add a 5-alpha reductase inhibitor, or 5-ARI, which actually shrinks the prostate over time. For guys with both an enlarged prostate and really bad symptoms, starting with combination therapy right off the bat is often the way to go. And finally, if they still have those pesky storage symptoms, you can add an antimuscarinic agent to the mix.
Okay, let's switch gears and talk about managing patients whose main problems are those storage symptoms or an overactive bladder, that classic trio of urgency, frequency, and urge incontinence. And just like with voiding symptoms, we always start with conservative measures. That means moderating fluid intake for sure. But the real cornerstone for overactive bladder is supervised bladder retraining. This is a structured therapy designed to gradually stretch the time between voids and help the patient regain control.
When those conservative approaches just don't cut it, the first-line medication we reach for is an antimuscarinic, which you might also know as an anticholinergic.
These drugs work by helping the main bladder muscle, the detrusor, to relax, which increases the bladder's capacity. Now, for exam purposes, it is definitely worth knowing the specific first-line drugs that NICE recommends. We're talking about immediate-release oxybutynin, immediate-release tolterodine, or a once-daily version of darfanisin.
So what if those first-line antimuscarinics don't work? Or the patient can't tolerate side effects like a dry mouth? Well, the next step is to think about a totally different class of drug, a beta-3 agonist, like mirabegron. It also helps the bladder relax, but it uses a different pathway, which often means fewer of those annoying side effects.
For our final section, we're going to put a special focus on nocturia. Waking up at night to use the bathroom can be one of the absolute most bothersome symptoms for patients, and it really needs its own targeted approach.
The strategy here starts simply. Advise patients to cut back on fluids in the evening a few hours before bed. A really interesting second-line option is actually the paradoxical use of a diuretic. Giving furosemide in the late afternoon makes the patient have a big wee before they go to sleep, which helps keep the bladder emptier overnight. And for really persistent cases, you can consider desmopressin, which is a hormone analog that directly cuts down on how much urine the kidneys produce at night.
So, to wrap it all up, the most crucial takeaway here is the importance of having a structured plan. First, you classify the patient's symptoms into their main group, voiding, storage, or post-micturition. Second, you use objective tools like the IPSS to actually quantify how bad things are. And third, you apply the right, evidence-based, stepwise management plan based on that initial workup.
And that brings us to the end. I'll just leave you with one final thought to take back to your own practice. How can you make better, more systematic use of a tool like the IPSS, not just at the first visit, but in every single follow-up, to objectively track how well your treatments are actually working?